Hello, Paul Auwaerter here. I'm the Clinical Director for Infectious Diseases at Johns Hopkins Hospital and also advisor for the Medscape Infectious Diseases pages. The topic that I thought I'd speak a little bit about today has to do with an old workhorse of infectious diseases and other physicians, and that is Piperacillin, Tazobactam, or Zosyn. This is the drug that's been available for quite a while. In fact, actually is off patent and has been widely used for pneumonia treatment, sepsis, intra-abdominal infections, post-operative infections, and so on. The reason I thought it would be worth spending a few minutes talking about this is something that was triggered by a discussion I had with Sarah Cosgrove last week, who runs our antibiotic management program. She alerted me to something that I think many of us who have looked at antibiotic susceptibilities of various bacteria have probably seen, but maybe not really quite understood the implications of. So what I'm speaking of, if you look at, for example, an E. coli that might be have been isolated from the blood, you'll see the break point for Piperacillin Tazobactam as being 16/4. However, if you look at Pseudomonas, that particular break point is 64/4. Now, for me, certainly Pseudomonas is generally bacteria that has a higher amount of resistance, and it now strikes me as a bit odd, as I'm thinking about it, that the MICs might be fourfold higher for Pseudomonas as opposed to Enterobacteriaceae. You know, the normal teaching point I make for infectious disease fellows treating pseudomonal infections is that you don't need Piperacillin Tazobactam because the beta-lactamase component, the Tazobactam, isn't necessary when treating Pseudomonas, and you can use Piperacillin alone. However, when I discussed this with Sarah Cosgrove and did a little more investigation, it seems that years ago, of course, most of the initial studies with Piperacillin Tazobactam, especially with Pseudomonas, were done in combination with aminoglycoside therapy. And so the old clinical standards that were established at that time assumed that Pseudomonas infections would be treated with a combination of aminoglycoside as well as Piperacillin Tazobactam, therefore setting the break point higher. Now, nowadays, although aminoglycosides might be used empirically, often we shy away from using them, and in fact often will use monotherapy to treat most pseudomonal infections. So the Clinical and Laboratory Standards Institute, the so-called CLSI that sets breakpoints, has been under some discussion now for over a year as to whether these breakpoints should be adjusted downwards to the 16/4 amount for Pseudomonas. Now, I've not seen any convincing data that's clearly said that monotherapy with Piperacillin Tazobactam, when you have pseudomonal isolates that have MIC 90s of 64/4, indeed have worse outcomes or so on. However, I think as I now treat people in the hospital, I'll look a bit more closely at the actual MIC 90 and perhaps shy away from using Piperacillin Tazobactam for Pseudomonas if I see some of the higher MIC values. I think it might be interesting to see if this is an issue in your own practices, and of course if these breakpoints do change, there may be some lessening of the apparent susceptibility profiles of Piperacillin Tazobactam against Pseudomonas, which historically have maintained quite good levels, but of course may be less so if the breakpoints will be revised downwards. Some food for thought, and thank you very much for listening.